Thank you so much, everybody, for joining us today. My name is Erik Valera, and I'm Program Director for Latinos in the Deep South here at the Latino Commission on AIDS, and I'm really excited to be able to present for you guys today and introduce you to one of our newest colleagues, Dr. David Garcia, who has recently joined us as the Director of Capacity Building and Research here at the Latino Commission on AIDS. So please help me welcome Dr. David Garcia.
Hello, everyone. Thank you so much for your patience. I appreciate that there's so much interest in this call. And as Erik mentioned, I am the newly minted Director of Capacity Building, Research, and Evaluation with the Latino Commission on AIDS. And my background has always been in HIV prevention, primarily working with community-based organizations in Houston, Texas, Milwaukee, Wisconsin, Seattle, and now New York City. And I'm looking forward to having some exciting conversation today with all of you guys. So thank you.
Thank you, David. And so this webinar, for everybody to understand, this webinar is really just to summarize the latest update of the National HIV AIDS strategy. Our programs here serve to advocate and strengthen community-based organizations and be able to help them stay sustainable, as we are a community-based organization ourselves. So we want to really be able to offer our interpretation of this latest updates of the National HIV AIDS strategy as it applies to community-based organizations. So we want to pay particular attention to how to be able to position ourselves and to position community-based organizations in this new funding landscape. So having said that, what we're going to be speaking about, we're going to be going back and forth. This is as if we're having a cup of coffee, and we're going to be talking about what we know about the latest NHAS update. So the opinions that we express are our own.
So a little bit about what we're going to cover today is, we're going to give you some background by really defining what we feel is a community-based organization, and with the vision of the document and the context, and also accomplishments that have contributed to HIV prevention and as a result of the very first strategy, and the framework of this new update, and we'll outline the 4 goals of the update and really look at how these are going to affect community-based organizations. And then hopefully we'll bring together a nice conclusion for everyone so that we can get your input, and hopefully you can glean some sort of information from what both Erik and I are talking about today.
So at this point, we want to hear a little bit from you. We want to know, and this kind of cut off a little bit, but I want to know if you've had an opportunity to read the latest National HIV/AIDS strategy update that was released on July 30th. So let us know, have you read it? Have you skimmed it? Is it just sitting on your desk but you haven't gotten to it yet, or were you just waiting for us to tell you about it? And we're getting a lot of responses, and they're coming in quickly. Quite a few people have skimmed it. Some have read it. Let's see. So far, skimming it is in the lead. It seems that most people have skimmed it and not read it. And you know what? That's fine. This is where we are right now, and this is something that we're going to be working on for the next 5 years, and this is the beginning. We want to be able to help you understand what we mean by when we're talking about community-based organizations. And in this context, we're talking about nonprofit organizations. They could be community organizations, faith-based tribal organizations with the capacity to impact HIV prevention services, medical or non-medical, on a community level, to do direct services, influencing policy, and or mobilizing communities. So Dr. Garcia and I are going to be having this back and forth conversation about NHAS 2015 update. And as I said, the commentary and interpretations are our own, and they're based on our experience and our perspective. as the Latino Commission on AIDS is a community-based organization, and we're really looking to be able to help strengthen our position as community-based organizations and those of our partners.
And so I hope that everyone, I want to assure you that Erik and I will do our best to summarize the strategies update and provide an engaging analysis along the way, but also understand that we don't have all the pieces to the puzzle quite yet. There's going to be an implementation plan released soon, and also we know that all of you are diverse experts as well in your own right, and so we hope to learn as much from you, if not from us, with your comments and your questions. And really today is just we want to initiate a conversation that's going to be part of a larger discussion as we move on throughout the next 5 years with this update. A little bit about the vision of the document. The United States will become a place where new HIV infections are rare, and when they occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstances, will have unfettered access to high-quality, life-extending care free of stigma and discrimination. So we know that the strategy was developed by the White House, the Office of National AIDS Policy in July of 2010, the very first strategy, and then it's been recently updated and released as of June 30th, 2015. And, you know, the methods in creating this strategy is that they had a task force of representatives, of scholars, of academics, of community people, as well as federal agencies that also work within HIV. And they also took into consideration the opinions and comments of private stakeholders via town hall meetings and also commentary via the website. So there was a lot of opportunity to provide input into this document.
That's right. And in 2010, the National HIV Strategy, this was the first time we had a National HIV Strategy in the United States, and it really has helped provide guidance across our field. It's helped us understand how both governmental and private resources are prioritized and how they're directed. And it guides decision-making on many different levels regarding everything from research to drug development, even implementation of social programs. Oftentimes, I'm sure that if any of us are grant writers, often cite the National HIV Strategy as justification for our funding proposals.
That's right, Erik. I think that those grant proposals that do incorporate the NHAS strategy are those that are the most compelling and most likely to be funded, especially part of this new framework and funding framework that we're working with. And we know that the accomplishments since 2010 with the very first strategy are that we've had the implementation of the Affordable Care Act. And what this has done is this has helped to increase more access, right, for individuals to gain health care. But unfortunately, I think that we're seeing that there could still be racism involved and that those that may need it the most may still have some sort of barriers. And so I know that APHA is about to have a webinar talking about this very soon. But regardless, we do know that preventive services, including HIV testing, though, are now more accessible, and that there have been expanded coverage options through Medicaid or the marketplace, and also that it ended discrimination of HIV, meaning that it ensures coverage now for pre-existing conditions.
Absolutely. And, you know, and I think an important point to this is that when we're looking at the Affordable Care Act, a lot of this is based on how it's implemented from state to state. And so we also, as we go through this, have to understand that when we're looking at community-based organizations, we're not necessarily looking at the broader nation. We're looking at what we could do to impact the community in which we live in. So that's the perspective that we're going to be looking at as we're going back and forth and looking ahead at this strategy towards 2020. We've also seen a lot of innovations of research and technologies for early treatments. For HIV reduces the risk of onward transmission by 96%, while simultaneously improving health outcomes. And this is from the results from HPTN 052, which really was a game changer. It was Science Magazine's Breakthrough of the Year in 2011, because it really has changed our field. Now, what used to be prevention, what used to be separated as prevention and care, is now treatment as prevention, or I would like to say treatment is prevention. As well, we've seen a rise in PrEP. In July of 2012, the Food and Drug Administration approved Truvada, as the brand name Truvada, as a pill for pre-exposure prophylactics. This was something that hadn't existed prior to the 2010 strategy. And as more studies are coming out and the more we learn that the better people adhere to PrEP, the more protected they are, the more importance it's having as a strategy to be able to continue to prevent HIV, as well as new line HIV testing, fourth generation testing. We're being able to close the window, our new technologies are able to close the window periods even sooner. And these are all really important technologies that are being, that we're using now and that we're implementing in order to be able to make a larger impact and really be able to get to the heart of the epidemic.
Exactly. I think this is a very exciting time. The idea that we have these new HIV tests that can detect HIV sooner after infection, that we know that PrEP works when you take it daily, and when you combine it with other methods of protection, it's even better. We just have to try to get the access to individuals, right? And I think that's what the goal of this new strategy is going to be about. How can we get individuals to access these new innovations?
Absolutely, yeah. And, we have a fact sheet, it's the right, to be able to get to the right people, to the right places, using the right practices. And we're going to be speaking a little bit more about what that means, especially for on a community level.
So the framework of the document is that, we have to acknowledge that there's still an HIV epidemic, right? That we are doing our best to combat it, but there's still this epidemic present, and that people can live long, healthy lives with HIV. I think this is very important because it helps to destigmatize HIV infection. Also, that certain populations are disproportionately affected. We do know that there are priority populations that have had this burden of the disease, unfortunately, and everyone deserves access to prevention tools and education, and everyone deserves immediate access to treatment and care.
Absolutely, and we have a comment that is asking, do you think that that HIV medication, making HIV medications too expensive for insurance to cover cause, in quote, Cadillac tax? And I think that's a really good question. A lot of the programs that we have around HIV are as much public health programs, not entitlements. And so it's important to to look ahead and think operationally what it is, how it is that we as community-based organizations need to look out for moving forward.
So these are the overarching goals of the document. The first one being that we reduce new HIV infections. The second being that we increase access to care and improve the health outcomes of those individuals that are living with HIV. Also that we reduce HIV-related disparities and any health inequities. And the fourth, that we achieve a more coordinated national response, that we are talking to one another on a national level to try to combat the HIV epidemic. So the first goal, just fleshed out a little bit more, is that we know that we need to focus on priority populations, and there are national trends, but I think that community-based organizations need to think about who are the communities that they serve, and are their communities impacted, And conducting needs assessments is going to help them to understand what is their priority population as well. And I know that oftentimes we have to focus on priority populations because we have to follow the money. But I think that if you can build a strong case, if you have a priority population that is specific to your area, to who you are serving, you can find money somewhere because you can show that there is a need. The other is that we know that our HIV toolkit has grown, right? We know that it's beyond just condoms. We have PrEP, and that, I think, is amazing in itself. But how can we get PrEP to all our communities, and how can we get people to understand that PrEP is a great option, that it's something that if you're a person at risk of infection, that you can access. And then also that information should be universally integrated into appropriate educational access points, right? Whatever individual, when they access healthcare, this is an opportunity to also engage them in education, right? And there's a lot of different access points in which we can engage individuals in learning about PrEP and learning about new innovations or new testing strategies and learning about ways that they can talk to their partners.
Absolutely, and so, thinking about that, this in terms of the priority populations particularly, the National HIV Strategy has a list of demographics of those who are impacted, and this is really based on epidemiological data that we're seeing nationwide. Particularly, we're seeing amongst men who have sex with men, particularly men who have sex with men of color, black men, young black men particularly, and Latinos, women, injection drug users, trans, the trans community, and so they're seeing this on a national level, and so it's also really important to understand what the social and the structural determinants are which are leading to risk on the community level. Things like poverty, discrimination, stigma, homophobia, really understanding specifically where HIV exists in your community. So looking at this slide, and this is directly from it, we're looking at it from the standpoint of race and ethnicity, transmission category, age, and region. And so all of these are very important factors, and this is what we would normally refer to as data indicators. And data indicators on a national level give us a very broad perspective. And as we were talking yesterday, David, I'm right now calling in from Chapel Hill, North Carolina, and in this, when we're looking at the geography of this, we're looking at the South as a risk factor. So we're talking about a very large set of states in all of itself being a risk factor. However, what we also need to understand this is that we can't paint the South with a broad brush. I'm calling in from Chapel Hill, Orange County, North Carolina. I could throw a stone and hit Durham, North Carolina. And the difference between the incidence rates in Orange County and Durham, North Carolina are very different. So the strategies that would need to be approached from one community to the other would also need to be very different. And that's a very important thing to understand because within an impacted community, there's also very specific demographics. Understanding whether in this geographical area, whether the transmission is occurring because of injection drug use, or is it occurring from male-to-male contact or heterosexual contact? And these are the things that our programs and organizations really need to get to the heart of in order to be able to make a justifiable case for who we're working with.
Exactly. I mean, that's the asset of the community-based organization, is that we know the communities that we work with. We know them best. And so we need to develop and think strategically, what are the methods to best serve the communities that we've been serving? How can we reduce new HIV infections? How can we focus on finding those positives, get them linked to care, get them on treatment, and keep them retained in care, right, so that we can suppress their viral load? And there's a lot of different strategies that, there could be couples HIV testing, there could be the social network strategies, there could be incorporating PrEP education as much as possible. There's a lot of ways that we can think creatively and as a CBOs to do this so that our communities get the information.
Yeah, and I think you hit the nail on the head right there when you said finding positives, because this strategy really focuses a lot more on case finding positives. There was a time when we would be doing testing events, and I've done these testing events, and I would come back to my boss and say that I've tested 300 people today and pat ourselves on the back, but every single one of them were negative. And so when we're looking at how resources are being used, particularly public resources, it really is much more about being able to help identify those people who are living with HIV and don't know they have it. And so that doesn't mean that we don't continue to test everybody. It just means that we have to diversify our funding streams in order to be able to do that. Because as I can tell, and speaking to community-based organizations and programs, program officers and managers are a lot more keen to how many positives we're finding.
Exactly.
The other part of that is that the expanding toolkit, which I think is a really important point to this first goal of this strategy, and thinking about it in terms of how community-based organizations need to retool themselves. Traditionally, I've seen that many organizations have focused on grant funding or charitable donations, and many of the programs have been focused primarily on behavioral modification. And so I think one of the things that I'm reading into this is that it really is a lot more about combination prevention. Programs need to be working to incorporate testing, PrEP, PEP, access to condoms, access to sterile syringes wherever appropriate, and working with positives in their partners, and STI screening particularly, being able to work well with in the areas of STI and hepatitis C, particularly as co-infections.
Exactly. So our second goal is definitely to try to increase access to care and also just improve the health outcomes of individuals living with HIV. And this is going to really require that we establish better systems, a seamless system to link people to care immediately. So that individual, we diagnose them as positive, we need to link them to care immediately and follow through and make sure that they are retained in care, because the idea is that we want them to achieve viral suppression, because this will maximize their health. They're going to have access to early treatment, better health outcomes, and then they're going to reduce transmission risk to their partners and to their community. And we need to take deliberate steps to really increase the capacity of these systems, right, as well as the number and the diversity of available providers. Also, our HIV workforce, right? Make sure that our HIV workforce is constantly getting trained in methods to be able to increase this and make this system more seamless. Those in clinical care and non-clinical care as it relates to people with HIV, and also support comprehensive, coordinated, patient-centered care for people living with HIV, including addressing HIV-related conditions, challenges, meeting their basic needs, right? So, again, this is, if you're not providing clinical care, if you are a CBO that does not do clinical work, then when you do your referral, then, follow up with your client, right? Your client hopefully will be returning to your organization. Make sure that they're attending their visit. Have you been to your visit lately? What are your medical labs? Collecting all this data is going to be vital also to the sustainability of community-based organizations. And then also it shows that you have a vested interest in your client, that you are concerned about their health. And ultimately that's all we ever want to feel, right? We want to feel that someone cares about us. And I think that those little steps can make a really big impact.
Yeah, you know, I love that you said that, because it really is about being able to help make this personal. You know, a strategy sometimes feels like you're taking the personality out of it, but we can't escape that. Even when we're talking about policies and actions, that we're talking about people in real lives, and the community-based organizations are those who are providing direct services every single day, and providing that personal touch, and are, for the most part, the cornerstone that keeps everything together for us, because they're the ones that keep the relationship with the patients and with the clients that really need these services.
Exactly.
And thinking about it in terms, you know, this is the HIV continuum of care. We often know it as a cascade, but, you know, we're thinking about, we've made a lot of strides in this since we've been using this as a tool. We've been learning a little bit more about where we really do we need to make the most impact. And the guidance that we're getting now is really, it's about, very much about that linkage piece. And you can't say linkage without retention, because if without retention, you kind of lose the link. So when I say linkage, I'm just as well implying that effort needs to continue to happen in order to be able to make that link happen. As we are able to continue to keep people re-engaged in care, that's really where we're looking to be able to level what we would refer to as this cascade, to be able to help people have higher levels of viral suppression. And I see a comment here is CBOs also need to strengthen the relationship with the medical providers to enhance effective linkage to care. And I have to completely agree with that. What do you think?
This is exactly what I was talking to you about yesterday. I think that if you are that CBO who is not providing medical services, then make sure that you have that relationship strengthened somehow. Go by, visit the FQHC, the ones that, talk to them. And there could be more than one FQHC, so it could take some time, but we've got to make sure that we have this relationship developed and that we're communicating a little bit more. At the same time, when your client comes back to you, you can get that information from them as well, right? You can say, have you been to your doctor's visit in the last 60 days? Yes or no? Mm-hmm. What is the results of your latest your blood work? Are you virally suppressed? I think collecting all of those data points is going to help CBOs to sustain, so that they can say X amount of our patients, our clients, are engaged in care. X amount of our clients are prescribed ART. X amount are virally suppressed. This is what's going to set your grant application apart from others, because you can show that you are aligned with the National HIV/AIDS strategy, and you can show that you are demonstrating some impact on your community.
Yeah, absolutely. In the CDC's compendium of HIV prevention has many evidence-based interventions that are able to be used on a community level, and knowing that it's evidence-based and that it's been tried in communities is really a justification to be able to for funders. Even if it's not a top line high impact prevention intervention, depending on who the funder is and depending on how you're using this grant, knowing how you're being able to justify that you are making an effort or that you are working in the realm of re-engagement, being able to help people take their pills, reminding them to be able to take their pills, and really supporting them, calling them up and saying, do you have a ride to your clinic appointment? Sometimes that's what's needed to be able to demonstrate that you're making that impact.
Exactly. I think just making sure that we attempt to try to work with as many FQHCs or clinics in our community that our community members, that our clients could be attending, so that relationship is good, right? We're all in bed together, so we need to make sure that we're all happy and that we're all being served very well.
One of the models that I see here that is often used is the medical home model. And this is where a patient would go in and has their services provided for them, kind of a one-stop shop. And so even when you're in there, you have everything. You don't need to refer someone out. And by not having to refer someone out, you're able to provide these wraparound services that are needed right there. Having said that, the patient is still going to have to leave the clinic. And they're still going to need support when they go home, when they go to work, when they're with their families, to be able to speak to their partners and so forth. And that's where I think our services come in.
Right. And I also just want to highlight, that there are these evidence-based strategies and interventions that can support linkage and retention in care, like ARDAS and CLEAR. And I think that CBOs can position themselves to learn to adapt this really well for their communities, and that it can also demonstrate a very big impact.
Absolutely. Thank you.
So let's see. So our goal 3 is to reduce HIV-related disparities and health inequities, and reduce HIV-related disparities in communities that are most at risk for HIV, to adopt structural approaches to reduce HIV and improve the health outcomes in these communities, and then also to reduce stigma and eliminate discrimination that's associated with HIV.
Absolutely, and this is I think particularly important, because I think this is the goal that helps us meet other goals. As when we were talking before, you had asked me what is the largest barrier that we're facing right now, and I really think it's stigma and disparities.
Right. I mean, because when you see the cascade, right, you see how it drops dramatically. That we seem to be doing a fairly good job of identifying people, getting them linked to care, but then we don't keep them in care. We don't keep them. We don't get them on medication, and then we don't get them suppressed. So, and I know that you mentioned you felt that stigma was playing a role in all of this.
Yeah, I think and that is and that's what I've seen in my experience of having worked in the community and also having worked in clinics, is the experience that people have when they leave the clinics. Oftentimes, we don't really understand how people are stigmatized, or how we are stigmatized ourselves. I've seen examples of, by the mere fact of an organization having a red ribbon, that being a barrier to people wanting to go in there, because all of a sudden they're associated with something which they stigmatize.
Right.
And so that's to say that's not the intention of what that ribbon is about, but it's understanding who our clients are and understanding how our clients respond to our services, to be able to help address what these stigmas are, and particularly institutional stigmas. I think that's really hard when us ourselves become that social barrier.
Exactly. I mean, I can think about my time in Houston, Texas, and I did some research with transgender individuals, and they would talk about their experiences accessing health care, and that they would be treated poorly from the receptionist to the nurse practitioner or the nurse to meeting with the medical provider. And so, that stigma keeps them from accessing health services when they need it again. And they often would report that they would treat themselves at home if they were sick, because they didn't want to go through that experience of being so discriminated when they went to access care.
Yeah, absolutely. And as you're talking about Houston, a buddy of mine from Houston right now is just reminding me that about how HIV exposure laws have become a barrier themselves. Laws sometimes become slow to change, And there has, as in the National HIV strategy, there is guidance in asking from the Department of Justice, asking lawmakers to review the laws that they have on their books on local and state levels, and update them if necessary in order to be able to meet the needs of this strategy.
Right, exactly. And and then just because I know that this just happened yesterday in our meeting, we were discussing several case studies of individuals that were diagnosed and linked to care, and they were not able to access care because they were discriminated in some capacity, because they were immigrants or they lacked health insurance. And so, it really requires, this is probably the loftiest goal, I think. This is the one that's a little bit more difficult, because it's going to require a huge intervention, a structural intervention. But it can be done incrementally, and I think it requires CBOs to be the first to do so. It can be small incremental steps where you have your bathrooms are not, there's no gender specific to your bathroom, that you have signs posted in your lobby that you are inclusive of everyone, and that you have staff that represents the communities that you serve. Those are the baby steps, but then it needs to delve a little bit further with more education, more training, more competency, cultural competency.
Absolutely. And so in thinking about that in terms of cultural competency itself, the National HIV strategy also helps us understand across the nation how disparities and inequities continue to exist by race and by gender. And so I think what this is really telling us is that we really need to understand what this looks like in our own communities, and how to be able to address it in a fact-based way. Understanding that in our communities there's a particular incidence where the stigma exists. Does it exist across race or ethnicity, across gender, across age? These are, we have the information in this which tells us across the country, but it might be different where you are now in Chelsea, New York, than let's say just a few miles away in the Bronx.
Yeah, no, definitely. I think, this is why it's so important to really look at the specific geographic area that you serve, right? I think CBOs, although New York City, our transit system, people can get anywhere fairly quickly, or, it could take a little bit of time, but people will use the transit system to get to the other boroughs, and they're willing to travel if they know that they can get good health care. And I have seen that at an FQHC that I worked at, and that individuals are coming from other boroughs. But it's also important to look at where you're at, what's the geography that you're serving, and what is the population in that area, right? Who is your community? How are you serving them? And definitely the Bronx, totally different from Chelsea, right? So one specific type of intervention tailored for Chelsea is not going to work so well if we're going to target Black or Latino men in the Bronx. So let's see. Our fourth goal is to achieve just a more coordinated response on a national level, to really think about how we can communicate better. Communication is always key. We can say this over and over, but what are the steps that we're doing to make sure that we're communicating better, right? Now we live in this amazing technological world. We can text, we can email, we can, but I think calling them up is always, the old school great way of making sure that we're maintaining communication. And this is, not only just within community-based organizations, also with your local health department, with your federal government as well, all the different agencies that you might have funding from at a federal level. And then to develop mechanisms to monitor your impact, right? How are you achieving these goals? How are you contributing to them? And I think most importantly, how are you contributing to the cascade, right? The continuum of care.
Yeah, this where this to me speaks about collaboration. And there was, I think a really big shift since the 2010 and the strategy was first developed, where we started to see a lot less overlap in services and a lot more emphasis on collaborative programs and integrating programs so that we're not losing resources. And I think that this is something really important that is that we're looking at across federal agencies and governmental agencies, but it's just as much applied, but those are also, for the most part, many of our funding sources, and that just as well applies to those of us that are privately not 501c3 funded.
Right. No, I mean, collaboration, without a doubt, is key here. And, I've worked with organizations that, they say, oh, I collaborate with this group and I collaborate with this group, but do you have an MOU established with them? Do you have specific outcomes that you require of each other? And are you maintaining communication? I know that email is a great way, but let's meet face to face, once a quarter, so that we can make sure that our communication, our collaboration is key and it's fundamental there.
Yeah, this is, I think, often a challenge on a community level because it only really takes one person to mess up a relationship with another organization, and that person can be anywhere in the organizational chart. And so, I think that this is really where community-based organizations are really challenged in being able to tighten up and develop their own strategies, their own internal strategies, their own internal policies and protocols of how to be able to make decisions in the field.
No, I mean, I agree. I've definitely seen that as well in my experience. I just think that we need to always keep our eye on the goal, right? We are all on the same mission to try to eliminate HIV and to try to reduce HIV infections and try to identify the individuals that are positive and get them into care. But, if we let our egos get in the way, then that's not going to be good, right? It's going to require good interpersonal communication so that individuals are able to talk through things. A lot of times, most of these instances, those kind of issues are due to miscommunication. And so it really just takes, maybe the ED calling up the other executive director and saying, hey, let's talk this out. Let's go have a little coffee. Let's, we want to make sure that we're serving our community the best that we can.
Yeah, absolutely. I want to bring in a question and address it to you, David, that I'm seeing here on the chat feature. What specific tasks or things can a CBO do to educate its testers or outreach folks on PrEP or PEP? And the second part of the question is, are there existing examples of other online or in-person trainings for such roles so that there is a consistent level of competency when they talk to clients?
I mean, I think that's a great question because I think that right now we're at that specific stage because PrEP is such a new innovation that now we're at the stage of implementation, right? We're implementing it in our communities, and we're trying to get people to have access to it. But with implementation, it requires this education, right? That we train the workforce that is delivering the message, that they're delivering it well, and that we also train and educate our communities with those messages. And, I can't speak if there is a specific training that online or anything, but I can look that up and I can get back to them. But I do know that we here at the Commission are about to embark on a huge education training project called Preparándonos, or Let's Get Prepared, in which we are targeting specific cities. And if we're coming to a city near you, then I invite you to apply to become a part of this training. It's, I believe, a 2-day training in which you will train the trainer. You will get the skills to be able to train others about PrEP and about the importance of PrEP and about how they can access PrEP through the different types of mechanisms, insurance mechanisms, or if you lack insurance and so forth.
I'm really excited. I'm really excited about us rolling that out. And we've also recently did a workshop that we've developed, looking at how to be able to create new messages for our current landscape. There used to be a time when it was all about condoms and getting people to use condoms. But today, as we're talking about with so many expanding tools, it's not just about condoms anymore. Condoms are still part of the toolkit, but we need to be able to refine our messages so that we help people understand that there's more ways to be protected than just condoms. And all of the different ways, including treatment as prevention, PrEP, PEP, so that people are able to make informed choices and be able to make those decisions that they need to make on their own and have access to those tools.
Exactly. That's the key thing, is the access, and we want to make sure that everyone gets that access.
Yeah, it's difficult. I think it's hard for many of us also to kind of move past that because it is so much more of a complicated message than it used to be.
Correct.
Another person, when we're talking about stigma, chimed in and asked if we could talk about racial discrimination, which I think is a very important part of this as well. And in thinking about racial discrimination, I'm really thinking about the social and the structural determinants which lead to HIV risk, which are a direct result of institutional racism and homophobias, and the way that many of our systems have worked. And I think that this is really where that third goal really comes in, is looking at helping us really have that honest conversation and understand, does racial discrimination exist in our community? How does it exist? And how can we use that? What do we have to be able to help combat that in order to be able to prevent further infections and to be able to keep those who are infected at their optimal health?
I totally agree. I think whoever sent that comment in, they really put their finger right on the pulse of one of the big problems, is that, racism, unfortunately, it exists, and we acknowledge that it exists. To be a black man in New York City is a different experience, when they wake up, when they walk out the door, the way they are treated is different from others. And the same for Latinos, right? We know that we are constantly under this level of stress, this level that's associated with racism that impacts our health, our quality of life. And all of that also impacts our financial resources, the jobs that we maintain, our relationships, and whether we can access health care. And so sometimes I think it can be very difficult to be a person of color when you are dealing in this larger, with issues that where health may not be one of the most pressing, unfortunately. And so we have to try to engage those individuals, and we have to be those organizations that are led by people of color that know our communities the best, so that we can get those people to a safe place where they're not going to feel discriminated, they're not going to feel the racism, where they feel at home, and then they're going to be engaged in their care.
Yeah, that's really important, and I think that, and I really appreciate being able to talk about that and hoping that these conversations continue. But we only have an hour here, and I think it's time to start bringing it together. So we're gonna try to get to some conclusion points, and then we're gonna have a few minutes at the end to be able to have some more questions.
Cool.
So thinking about this in terms of federal funding for HIV testing programs, are to focus on finding unidentified cases of HIV positive. So this is really where a lot of the investment is, especially from the federal government and indirectly through state and local health departments. And so there was a time when we would be able to get credit for as many tests as we did. But now we really have to start looking at our alternative funding sources to be able to provide that universal testing. And so it's really key to be able to stay sustainable, to think about how we're finding positives and how we're funding our testing programs. As well, community-based organizations should focus on combination prevention. It's not just a program on being able to curb behavior anymore. These programs are now, encouraged to include both behavioral, biomedical, structural, including condom and syringe distribution. The more combination you have, the more impact you're able to you're able to demonstrate within that. And I think one of the points that you continue to make, for us and even through this webinar, David, is being able to not just do that, but to monitor your successes and your failures. Be able to monitor what you're doing along the way.
No, definitely. You can learn so much from your failures, right? And you can inform other organizations about how something failed, and all of that is worthwhile because we want to conserve the resources, right? If something didn't work, tell us why it didn't work. That's just as important as when something does work.
Yeah, and you'll know better for the next time when you write it. When you write in, you'll be able to write in, this didn't work, so therefore we're going to do this.
Exactly. Also, we know that we need to better monitor this linkage to care, right? And I plugged in the CLEAR and the ARTIST, but, if there's an innovative way or strategy that you have, use it, talk about it. Why is it so innovative? If you know it works, then let's make sure that we're using it. And the reason we want this is that we want to make sure that individuals are getting diagnosed and access to treatment early, because we know, because of the latest study, the HPTN-052, that it's going to improve their health outcomes dramatically. And it's also going to help with reducing HIV transmission within the community, and also to continue stressing retention and care, right? Think about ways you can follow up with your clients. Are they maintaining their appointments? Are they also taking their medication? Have you been to your last appointment? Are you taking your regimen every day? Why are you not? How can I help you to take your regimen every day? And we know that primary care providers, and particularly those that reflect the demographics of your local epidemic, they are encouraged to serve people living with HIV. And programs utilizing the medical home model are encouraged to serve the holistic needs of patients. And holistic needs meaning, not only just their medical care, right? Their transportation needs. Do they have needs for their children? Do they have food needs? All of those, housing needs, substance abuse issues that they need to work through, because that's going to also help, I think, with the continuum of care, right, to improve it.
Absolutely. And, thinking about these primary care providers, we love our doctors, but I need to give a special shout out to our nurses and nurse practitioners and physicians assistants, because they are really the ones who are picking up a lot of the slack where we don't have to be able to, as we have expanding cases and getting more people into care. It's the importance of these providers, more than just the doctors, is invaluable.
Exactly.
And community-based programs are encouraged to address social and institutional level stigmas in communities vulnerable for HIV. Community programs are encouraged to collaborate in order to remain relevant in this current HIV landscape. So, it's really important to continue to work on this level, because as community-based programs, community-based organizations, as I said before, have the direct contact and really are the ones that make the difference in getting our patients and clients the services that they need. So at this point, we have we've set aside about 15 minutes here to be able to try to respond to as many questions or comments that we have along the way. So I want to bring in some of the comments that I'm seeing here. And David, a question for you. So somebody's asking is, what is the age for young adults? What do you characterize as the age for young adults in programs?
I think that's I think it's usually, I always want to change it, of course, because I want to always be considered a young adult. But I do believe, it can vary, and I think you can go up to 29 because we do know that we have this extended adolescence. I don't know what the EPI data is reflecting for young MSM because sometimes they say up to 29 and sometimes they say up to 24. I think that you can tailor that yourself. If you see, I think it'd be great to look at the data up to 29 and then look at the data for up to 24 and see where there's the greatest burden. But I would say within that age range about. I don't know. Do you have anything to add, Erik?
Yeah, well, because it's the difficult part of it is a lot of what we're talking about right now is within networks, and it's not out of the people don't age out of a network just because our programs tell them to. So if you have a program that's to 24, that doesn't mean that their social or sexual network is not of those that are 29. So there's two things here. I think one is how we tailor our programs, and then the other is what do our funders tell us, and what is the criteria for the funders, and being able to create a balance between those two. And sometimes I think that depending on who your funder is and depending on the grant, there might be a justification to be able to change that criteria. And I think in some cases it's rigid because of whoever the funding source is.
Exactly. I mean, I think if you can demonstrate that there's a bigger need amongst a much younger population that you're serving, then that is very worthwhile.
Another question we have here is, we see great outcomes, or comment, we see great outcomes, this is referring to Goal 4, with people living with HIV using the Ryan White programs, but hear from consumers that problems using newly acquired ACA private health insurance in conjunction with the Ryan White program services help maintain their services, hence medical care and treatment. What items are listed to educate and incorporate private physicians with the services provided with the Ryan White programs to assist maintaining health insurance through health insurance assistance service category?
I think that's an amazing question. I think it's always difficult when we try to engage private physicians. It can be a little bit more difficult. Hopefully our communities are going to private physicians that are specialized in HIV medical care, and then that can narrow it down a little bit more. But it really does require, I think, CBOs to be a little bit more proactive, right? To go out and try to meet with the private physician. And, I know it takes time, I know it takes money, but oftentimes it can be very difficult to engage physicians. It can be something where in Seattle, a group of HIV specialty care doctors used to have a monthly meeting that they would have, and it would be a dinner, something that was catered by a pharmaceutical, but they would never let the pharmaceutical present. And so they would have presentations from the community. And so if you can find an avenue, something similar to that, where are they congregating, or do they have this kind of the meetings where they're meeting together to talk about case studies? Because it would be interesting. They would talk about their clients coming in and how some of them were thorough sorting, and talk about the type of drugs they were using and how it might interfere with their drug regimen. So it's going to take thinking a little creative and being very proactive, I think. But I think that's a very difficult task. It can be difficult, but it can still be done.
Yeah, and I think that some of this also is very much regional, because I know that where I am in North Carolina, that the Affordable Care Act defaults to the federal exchanges, and Medicaid hadn't been expanded. There's had continued to be a push to be able to have patients who are uninsured be able to acquire their own health insurance rather than be on the rolls of Ryan White. However, because of the insurance environment, sometimes it became cost prohibitive. So I would hear, if it were $75, I would be able. If it was $75 a month, I would be able to afford it. But it's $100 a month, and that's just out of my price range. And I think like where you are in New York, I think that it's a different environment because you have your own exchanges and there is an expansion of Medicaid.
Right. Yeah, New York, I agree it's going to vary dramatically from place to place. Having grown up in Texas and now living in New York, it seems that, New York is doing a different job than Texas to be politically correct and making sure that individuals have access. And so, but ultimately I think it's going to take some work on a community level to try to work with physicians to make sure that they're understanding any sort of health care access in the area that could work.
Mm-hmm. There's another comment here. It says, it's not enough to have staff that represents the community. People internalize racism the same way they internalize homophobia. It's an interesting question. It's an interesting comment to be raised. What are your thoughts?
I absolutely agree. I think, this is the problem with racism is that it's a larger beast. And internalized racism, internalized homophobia. And, internalized homophobia could be something that is putting Latino and black men at risk of HIV, and that they are not acknowledging the fact that they're engaging in sexual activity with other men. And so, I think it's very difficult for us to try to create change for internalized racism or internalized homophobia. It's a process, and it's, you could teach an entire class, semester class on trying to teach innovative ways to help people understand that. It could be small things like with microaggressions, when people make these small little comments that still add to the discrimination and the effect of discrimination. And the whole idea is that, all of this internalized homophobia, internalized racism experienced every day, these small little aggressions that we experience, they do impact our health. They do impact our decisions. They impact what we do. And so we have to learn mechanisms to alleviate that stress, because it's the stress that affects us and it diminishes our quality of life. And so, I agree, it's internalized racism, homophobia, that's a bigger issue. That takes a lot of therapy.
It does, and I think that's also an area in helping us, at least within our workforce, to build capacity, particularly in the area of cultural competency. We oftentimes hire from within the field, and people come with a certain set of experiences. But I think it's up to us, particularly the capacity building providers, to be able to help people understand the world that we have to go outside of our own worldview, and that people are living different experiences, and to be able to cater to those different experiences, and to be respectful of people's choices of what kind of sex they want to have, or how they want to identify, or how they identify.
Right. No, I agree. I teach young nurses or young nurses to be, and I tell them, whatever your beliefs, because we're going to always bring in our own personal beliefs when we engage in some sort of direct service. None of that matters at that moment, because if you're dedicating yourself to the healthcare field, you're dedicating yourself to making sure that the individual who walks in that door is going to you're going to increase their health outcomes, that you're there to help them. And so not all your personal beliefs, all that needs to go out the window, right? You need to make sure that they're getting the services that they need. And I know it's difficult. It's a process. It's something that individuals have to learn. And especially with, the internalized racism, homophobia, they have to acknowledge that they have the problem, and that's what takes the longest oftentimes, acknowledge that they have this kind of belief about others and how they can work to combat it is then the next step.
Yes.
I love this topic, though. I love that it's very intense. So it's giving me ideas for future webinars.
It is, and it's important. This is what's I think conversations that are happening in office places all over the country, and I'm glad that we were able to have this in such a public forum.
I agree.
A comment here that I think New York is doing better because they have funding. Same for Los Angeles. And I can say, as working in, I've worked in Los Angeles, and now I'm in North Carolina, and also work for an organization that's headquartered in New York. I can see that funding is definitely important. But one of the things that I think is important to understand is how funding changes. And I think that at one point, a lot of our funding had been based on prevalence, and prevalence being specifically how many people have HIV in a particular geography. And there's a shift towards incidence, which is how many people are acquiring it within a certain set of time. And we're seeing that the incidence is rising in, particularly as you can see through the National HIV strategy, is in the South, in southern states. Some of the challenge in that is that many of the sparsely populated areas, rural areas particularly, may not be getting the type of funding that it is that they need. We still see that places that are heavily populated continue to get more, but we're seeing a shift that's occurring through the Secretary's Minority AIDS Initiative, the CAPAS grants. But I can understand how traditionally we would see this in that way. What do you think?
I think funding is always a concern, right? But we have to think about ways where we're not always limited by funding, right? Although I know that that's what keeps us here and that's what keeps us paid and fed and so forth, but, there are ways that we can do things that are cheaper and more cost-effective. And, I don't want to speak ill about New York because I do love New York, but I do think that they are funded at really large levels, and they may not be using it as effectively, unfortunately. Coming from Texas, I know that we did a lot more with the shoestring budget than, the budget that's here. And if we had the budget that we had in New York, we would do other big things there, I'm sure. So I know that that's a difficult topic, but it really requires us to, if you're not getting the funding, then, scream loudest. You talk to your elected officials, do some advocacy work, because that's really what will give you the money then, right? It's he who screams loudest, the squeaky wheel is the one that gets the oil. Just make sure that you are making your voice heard, that you have assessed the need for the specific funding that you need or to target a community, and I think that could work the best.
Absolutely, yeah. And participating in your local planning groups and care groups. Because this is where a lot of the decisions are made, and participation in those groups and being able to help people understand where a need isn't being met. Even on the local level, you're going to be able to you'll have an opportunity to be able to direct resources to where they're needed. So, David,
yeah.
You know what? I've been having so much fun here, but this is all the time that we've allotted for this webinar.
And great. Thank you, Erik.
I apologize to everybody who, if we weren't able to get to your questions or your comments, but we do want to continue this conversation with all of you. And this is, we're going to have this strategy for the next 5 years, and we want to be able to work with you. Here's our email addresses. Please email us, contact us if there's anything that we could do to be able to help build the capacity of your community-based organizations through a training or through technical assistance in any way. Please reach out to us, and we will work with you in order to be able to provide it for you. And if not us, we'll find someone who can. David, this is great for the first project that we're working on together. Thank you so much for doing this with me.
Thank you, Eric. This was great. I always enjoy chatting with you. And thank you, everyone, for participating today. I hope that you were able to glean something important and helpful. And please feel free to email us. And this is also our URL if you have any capacity needs.
Thank you, everybody, and have the great rest of your day.